All right. Well, we'll get started in the interest of everyone's time. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. I'm excited for this, our first Value-Based Payment Models Learning Collaborative 201. So it's kind of an advanced or more in-depth curriculum than our previous learning collaboratives based on value-based payment models. So those of you who have managed to join, you do join via default, so please unmute your lines if you want to participate in the discussion. There should be fewer participants on the line, so there's really no need to be muted the entire time. We'll have, just like other presentations and collaboratives, we'll have presentations in the beginning and then questions at the end. We'll have possibly some homework assignments throughout. We have a website that you should have received email notification from Jesse. What's Jesse's last name? Truwin, what's his last name, Jesse? Not sure how to pronounce Jesse's last name. Jesse Trutwin should have emailed you your login information. If you do not have that, send me an email and I will follow up with Jesse and you offline following the collaborative. We have Shannon Calhoun, who is our subject matter expert, and she has more than enough years of experience that she would like me to not mention how many they are. She helped facilitate our previous learning collaborative this summer, and we were really excited about that and happy to have Shannon come back for a second learning collaborative. She has tons of healthcare experience, including leadership as well as healthcare or hospital-based experience. I don't have a whole lot of preliminary stuff other than that. Shannon, Andy, what else am I forgetting? The external website, we will meet every Wednesday at 2 p.m. except one or two cases. Next week we moved the learning collaborative due to the Task 90 webinar overlap, and then the Task 90 webinar got moved. So we can discuss whether or not we can move the learning collaborative back to 2 if that works for everyone, or keep it at noon. And otherwise we'll meet once a week for 6 weeks, and we will go to the first week of September, which will be September 4th. At the conclusion of the learning collaborative, we will ask everyone to complete and submit action plans based on the learning collaborative. We want to help you guys identify an activity based on an action plan, action item that you hope to or plan to facilitate in your state based on the learning collaborative. So that will be the outcome of the learning collaborative, and I will facilitate wrap interviews with each participant at 3 months and 6 months following the learning collaborative to check in and see how things are going, to see what resources we can offer, and as I said, as an evaluation of the learning collaborative to see how effective these were. Yeah, that's kind of the structure of it. Thank you guys for taking the time and the interest in participating. Shannon, do you want to take it away and we can get everyone introduced and get started?
Sure, I would be happy to. First, thank you for the introduction, and hopefully everyone had the chance to do that quick brief survey at the beginning. If you didn't, give us a shout now so we can make sure we get you included. We just want to know what your understanding is at this point and how we can help you move forward in value-based payments. So let me see if I do have control. Yep, excellent. So thank you both, Andrew and Caleb, for supporting me on doing this series of webinars for you and the Flex coordinators. This is a 2.0 or 201, sponsored, of course, by the National Rural Health Resource Center, who is very embedded and committed to the work in transitions of value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. I think we'll touch a little bit on every one of those over the next 6 weeks, so I'm happy to talk with you about all that. This is the context of the next 6 weeks in the webinar series. My goal is to help you have a better understanding of the components of healthcare transformation, first and foremost in the leader of healthcare, which is Medicare, CMS, and then how that really affects transformation across critical access hospitals and rural health clinics. I also hope to, along the way, help you with tools and resources that help providers engage in transformation. I do hope this is interactive, and because we have a smaller group, please feel free to ask questions through the chat box all throughout the presentation. If you need to slow down or if you want a clarification, by all means, feel free to do so. Because some of you have more experience than others, I'll try to be somewhat broad. Those that have questions for more clarification, please do so. Those that are more experienced, please chime in. I appreciate interaction. I think that helps everyone. I've had experience for a couple of decades at least. Thank you, Caleb, for not exposing me to my age. But I'm very passionate about rural health care. I manage the network of rural hospitals. I didn't manage the hospitals, but the network owned by rural hospitals, and help them do a pretty big spectrum of work, including payer contracting and grants to build out things like diabetic self-management training and purchasing electronic medical records and building a health information exchange. I also have experience in the ACO field, starting one in Texas and then moving to work for an ACO enabler, one of the largest that supports rural, which is Caravan Health. Also worked with the Practice Transformation Network, the National Rural Accountable Care Consortium. All of that gave me the ability to sort of see on the scope the adoption and also the barriers for participation in value-based payments as it relates to being rural, and then specifically, you know, and uniquely at every site. So hopefully I can share with you those learnings, and we can see if that will help you in some way. So today's agenda is really about healthcare transformation. I will give you a brief preview of the webinar series so you can know what to expect. We may shift a little in the topics or broaden them based on your input and questions. So please contribute, and we can grow and evolve if we need to. I want to talk about the foundational elements of healthcare transformation, which might give us insight on how we can fashion responses specifically for rural, but still meeting the payer's needs. We'll talk about payment methodologies, and then ultimately the impact on rural health. That'll be a pretty high level, and each of those topics will begin to touch on, but maybe in a different perspective, or maybe a little bit deeper on the particular topic. So this is the series currently as it stands. The first one is really talking about CMS leading healthcare transformation and what it means to them in payment and delivery reform. The second one is the paradigm shift, and this looks at a broader scope beyond Medicare's position on healthcare transformation, and not only from a payer perspective, but a delivery perspective, and even maybe out there on those self-funded employment sides. What's really happening with the population and their expectation? What are the options and the framework built that gives us opportunities to be very successful in delivering health care? The third one is specifically about pay-for-value programs. We'll do a deep dive on ACOs because that's really the leading one for rural, but we'll talk about lessons learned there and then see what the other options are. Following that, we'll look into clinically integrated networks What are the opportunities and barriers for rural providers? Can that support their work and pay for value with Medicare, or can it actually lead the work for pay for value? We'll look at opportunities and barriers in both those two places. The fifth one is about tyranny of small numbers. This has been a passion of mine even in my high school years. When there are small numbers, the infrastructure, the approach to building infrastructure is very different than those with high volumes of numbers. And so we have to talk about what that solution is for rural providers and the success of specifically delivery reform. And then finally, the big picture results matter. It's really about learning how to tell your story and becoming the value proposition for payers. So with that, let's just jump on in to healthcare transformation. In particular, I want to just touch on what drove us to this point. How did we get here? Medicare is the largest payer in the country and maybe in the world as a single payer. It really started a conversation. I can remember as early as 1995 that we started talking about Medicare is not going to be here, Social Security is not going to be here, and it was really led by the idea of the entrance of baby boomers. It's an exponential growth into the retirement age of the population, and this in and of itself started people looking at trends, and the conversation was to bend the cost curve. Bending the cost curve, when I first heard it, really just meant maybe reducing access or reducing payments. But it really shifted when I started to learn more about Medicare's approach on what the total spend is on a patient. So I'm going to spend some time today talking about total patient spend versus denial of access. So this sort of summarizes what I just spoke of, but in a chart. And what's important in this slide is that in the early days when we started looking at slides like this, it was really just one line, and it was that top line looking at the escalation of what the costs to the taxpayers are in Medicare and perhaps even Medicaid. And the exponential change in growth, not that there's growth, everybody expected it, but exponentially how fast it's going. Over time, what's interesting is that we started really looking at the effect of what they dubbed as excess cost of growth. I really believe that this reflects on that excess really is talking about duplication, lack of inefficiency, and perhaps unnecessary if prevention and wellness were in there. So the result of this early on, which is a real tipping point for the area of the government pot of money that pays for Medicare, is around the 2030 range. And at that point, we're going to be spending, at this rate of going, we're going to be spending over $1 trillion a year in healthcare, and that is not sustainable. So, and this is actually a faster growth of number than what we looked at 5 years ago. So the escalation is still happening in this growth, and it is of a big concern of those who manage the Medicaid finances. So this really drove Medicare to look at, how would we go about making changes? And there were initially 4 pillars. You can see those in the gray area: accountability, cost and quality. Really they talked about coordination. That was the really bigger term. And then patient-centered care. I went back and listened to Seema Verma's speech maybe about I listened to it this week, but it was a conversation that she had about a year ago. And the words translated in these pillars to something a little bit different. And the first one in innovation now translates to reducing barriers to value-driven care. The second one is about realigning incentives. And for me, I start thinking about where we are and where we're going to go. So for instance, this realign of incentives is leaving the idea of reactive transactional care into proactive prevention and wellness care. And payment is aligned with those two types of changes. From transactional, a patient gets sick, they come in, you treat them, they go home, and you wait until they come back, and then you do the same thing over again. Nobody's getting paid for taking care of them in advance or controlling something. certainly the doctors want to do that, but that's not the payment methodology. So there's a shift, and almost every one of these represents a shift. To me, increase of competition really means that there has to be collaboration, and their words on delivery system integration means that accountability is really across all providers who touch a single patient. It's a team effort, and when you dig really deep in the payment, you can see how that comes to pass, and hopefully we can have some conversations about that. I find it interesting that the person-centered care now changes to empower patients, and we see that in the new portals, telehealth, options and choices. So it's evolving as it goes along. It's very interesting to see where it will go. Obviously, we're in a transitional stage, and even in these foundational elements that Medicare put out probably 2011, maybe 2012. This is an older slide. You can see on the blue arrow, and sorry for the fine print, I'll talk through them, but those are those first foundational elements. And what I like about this slide is that the left X and Y graph was the current state, probably 2014 or 2015, and you can see the majority of the work is in fee-for-service, that orange bubble in the left corner. And you could see that there was starting to be some work across the spectrum all the way up to population-based payments. That's sort of capitation for those of you that might know that term. It's an all-in payment, not just on top of fee-for-service. And then if you look at the future state, and I would suspect that this future state picture has probably changed some. I don't know if they're going to update it, but what the example of this is that even though the orange dot reduces down to a dot instead of a big bubble, they're looking for places of success for almost every type of delivery. And so we can see as Medicare is pushing out different types of payment models, it's not a one-for-all type of solution. And so I'll talk more about that, but I'm encouraged that there's a place for almost everyone if you really consider what this chart is representing. So along came the ACA, or the Accountable Care Act, and a partner to that was the law, Medicare Access and CHIP Reauthorization. Obviously, this was bipartisan and very well supported, and it was an opportunity for Congress, who had ignored the physician fee schedule and any adjustments to that for almost 16 years, to find a place to actually do something significant. So it was historical and very important. That was called the doc fix, where basically they kicked the can, tried to tie it to inflation on the fee schedule for increases, and really do nothing else to change the payment methodology. So that was called the sustainable growth rate. So first and foremost, MACRA stopped the doc fix and the sustainable growth rate. Second, they created a program, the Quality Payment Program. This is actually the implementation of the law. And third, they required that payments are, Medicare payments are linked to quality of care, either through MIPS or alternative payment models. So this really needs to be taken to heart, because they're not backing off of it. We can see that in almost everything I'll talk about today. It's not like an exception, or maybe somebody's not going to be there or exposed to that. It's going to continue, that it's going to be linked to quality and cost through some methodology within the MIPS and APM. These are objectives. I'm not going to read all of them, but I think what's important is those first three: improved health, improved care, and lower costs, were what we call the triple aim. There's some other important tidbits that are in this objective page. One of them is that they're going to advance the use of health information between allied providers and patients. This one is a really difficult one to do because of the lack of standardization of data sets, the lack of the place in which people document in their EMRs, and the ability to create consistencies and discrete data to be able to do that. But we've seen a lot of efforts on that. That was early in the Meaningful Use PQRS and those other acronyms that followed that really moved us to a point to see that they're working to have consistent data that at some point can become patient-centric and not provider siloed. So that's happening. I think it's still new to see patients as members of their care team, but in the last year we're starting to see some ways in which that's going to increase that. Sharing data in a different way. Medicare's got some interesting things coming out this year where patients will have access to more information, some requirements that are stepping up on the providers sharing information. So that's really interesting to watch and see how that happens. And then the other thing that I thought was really important in this was to expand alternative payment model participation. They are very serious about that. They don't say expand the merit-based incentive payment system. They say expand the alternative payment model. MIPS is a training ramp to move into the alternative payment model. And today I will highlight what I see the differences are and the critical concerns of sitting and staying only in the MIPS side of the house. So we'll talk about that. And finally, I've already demonstrated that certainly continuous improvement of the QPP or the quality payment program we can see happening specifically this year. It's a launch year, 2019. We're making some shifts. So we'll talk about that in one of the next few slides. So let's talk about MIPS versus alternative payment models. An alternative payment model by definition is a payment approach that gives incentives, added incentives to provide high quality and cost efficient care. And that can be horizontal or vertical, meaning it can be specific in condition or episode or population. And it can also be specific by type of provider, I think, as well. So I think this is ultimately an important perspective, and we'll come back and look at that as it applies to the next couple of slides. The other thing is that originally, when the law first came out, we just talked about APMs and MIPS. But what has happened is they've extended the definition of MIPS, and I think that extension has really been affected specifically by the amount of population in a practice that's participating in the APM and the amount of risk that a provider is taking by going into an APM. That's what we see either in advanced APMs or what they call qualified alternative payment models. So there started to get to be this mix of you could be in an ATM but still subject to the merit-based incentive payment system. And there was some benefits to that for a while. It really helped providers, again, engage without too much commitment to loss, commitment to the possibility of loss equal to the possibility of gain. But that is eroding, and I think that the incentive to be in an alternative payment creates disadvantage to being in the MIPS alternative payment model. So I'll be happy to share that with you. It's about 2 slides down. We'll get to that. To further the conversation about what an alternative payment model is, let's just use the example from a high level of a Medicare Shared Savings Accountable Care Organization. The MSSP is a specific subset of ACOs, and it's about risk sharing with Medicare. It has up and downside risk. Upside meaning that if you create savings, Medicare is going to share that with you. Downside means if while you're in the program and your costs actually go up, you'll have to share in the losses with Medicare. Early on, there were ACO models that, of course, did not have to take any downside risk, and that is being escalated. So when you're in an ACO, it requires that you create a formation of an organization that is the sort of the tax ID number that contracts directly with Medicare to be an ACO, and where the shared savings goes for disbursement to the participants. There's usually a baseline number in order to be considered an ACO. 5,000 was the early numbers, and they thought that was where the sort of the break point for being able to be valuable to Medicare and successful for participants in the ACO. And under this contract with Medicare, providers agree to be measured in cost and quality of a defined population. The reason why it's a defined population is Medicare could be having multiple ACOs where patients may go from one side to the other, and they sort of need to draw the line on clearly where the patient is attributed so that they can actually see what's happening instead of sort of muddying the water to some degree. But the short end of the story is that the providers are agreeing to be measured on cost and quality of a defined population. In the shared savings program, the fee-for-service remained the same, so they still billed the same way, but under this measurement, they were able to either demonstrate savings or losses based on the requirements of the program to do specific things. And they were generally well-known activities that help save money, particularly prevention and wellness services like annual wellness and chronic care management programs. They also set an average total spend, and a lot of times early on in the program, people would consider that spend meant, what is Medicare spending on me, the provider? How much did I bill them? And in truth, Medicare is, by creating this accountability of providers, really wanting to know what the total spend is on a patient and a disease state, and then acknowledge that that needs to be the total split up by everyone that's treating that patient. So what they did was create a benchmark, and so everyone that was attributed to the ACO, Medicare literally would run the tax ID and NPI of every provider, look at every patient, then look at the total cost of every patient that was attributed, and then from the ACO create a benchmark of what the total average spend was on the entirety of the patient. Whether other providers that were seen by the patient were actually in the ACO, they wanted to look at the total patient spend, and that was the benchmark. And so it's very enlightening to see that, and I think if you haven't looked into that, let me know and we can talk about that to some degree. But what they're looking at is what are they spending overall, and then wanting everyone to be connected and have this understanding of the total spend on the patient and the disease state. The gift of being in an ACO, and I think in the future almost all alternative payment models, because Medicare is saying that this is a value, is that you get claims data, and not just the claims data of those data produced by the providers, but also the data for every place the patient has been. So you can all of a sudden see duplication of effort. You can see high cost places that patients have been where you didn't expect them to be, and really be insightful about the care and treatment that the patient's receiving and how you can, as a primary care provider, manage that patient better. So claims data is critically important. You can also see what your data is saying to the provider about you, the provider. So I consider that a huge gift. I did payer contracting for almost 20 years for almost 13 hospitals and on the commercial side. And if you don't know what the payers see on the claims about what you're doing, if you don't even know what's happening to that patient, you have no way to negotiate. It's really negotiating blind. And so having claims data is very, very powerful for almost everything, not just in the Medicare space only, but for everything that, sorry about that, for everything that the provider does in regard to payment. So claims data is a huge bonus. The other thing is working in the collective in the ACO gives legal protections, antitrust, STARK, and so forth. So having the ability to have leverage and collaboration couldn't happen outside of this ability of accountability across disparate tax ID numbers. So that's really looking at the alternative payment model. This slide focuses on, and by the way, this comes from our friends at the National Rural Accountable Care Consortium, but this slide focuses back on the fee schedule. If you were in MIPS and you were not subject to APMs, or even if you were in a MIPS APM, the point that's really critical to pay attention to is that the fee-for-service, the fee schedule itself will not be increased. Certainly, physicians that are in critical access hospitals, rural health clinics, may not have much billing on the fee schedule. But we haven't seen anything either on the increase of what's happening in the all-inclusive rates. which sometimes are connected to the fee schedule. So what you need to know here is that the fee schedule updates for a long time were only increased by percentages of the inflation rate. And once MACRA started, they gave them 5 years at a 0.5% to increase. They felt that that was sort of a boost to help them get through the starting points of MIPS. But if you notice, it goes flat. And it goes flat up until 2026, and then the only way that there'll be increases on fee-for-service payments, that's Part B billing, is 2026, and you'll only get 0.25% if you are not taking risk. So the result of that, in the graph below, you can see what the Medicare payment on a per PCP or specialist and the risk versus no risk. The bottom line almost stays below what it was prior to 2016. If you're taking into consideration the inflation and also the consideration of MIPS adjustments and shared savings. The opportunity to have revenue and do well is exactly the opposite. The opportunity in moving into this, if done correctly, has an opportunity to actually have a greater reimbursement and increase in your fee schedule, not in the existing fee schedule, but in value-based payments. Hopefully that's not too confusing, but it's really important to note that the fee schedule is flat, and that's even if you're in MIPS, nobody's getting an increase on the Part B billing. You only get it in incentives or engaging in MIPS or an APM. And this, not to beat a dead horse, but this is certainly the bell curve that continues. The whole curve continues to move to the right over time based on the balance of the entirety of those reporting to MIPS. What's important to note in this is that if you're in a MIPS APM, you would probably most likely be on the right-hand side of the bell curve. And that's because being in an APM, you get excluded from measurements of cost on your MIPS reporting, which gives you the ability to actually have a higher score because you're only measured on 3 things instead of 4 things, 1 cost, which you have no control over when you're in MIPS. So there's an immediate disadvantage of being in an MIPS only versus an APM. I think over time, as this evolves, it seems like it stacks an incentive to move, which has the counteracting effect of the disadvantage of not participating in MIPS or participating in MIPS without participating in an alternative payment model. It's very concerning to me, and this is a perfect example. This slide actually comes from data from CMS, but it's included with our friends from Caravan. It's probably the largest ACO enabler that serves rural providers and ACOs. But you can see in the 2017 MIPS scores what the average was based on small, rural, non-alternative payment models, all alternative payment models, and Caravan Health alternative payment models. If we look at the change in the weighted measures for cost scoring alone, the change of the ability to make a higher score without having cost information, aka claims data, is significant, especially for small and rural hospitals. You drop from 63 to 48, from 66 to 51 on non-APMs. And then on APMs, you're going to pretty much stay consistent because you're not losing that weight or measure if you're participating in a merit-based incentive payment system. So this added to looking at the bell curve, anyone choosing not to be in MIPS is not going to have any growth. Anyone choosing to be in MIPS only is going to continue to be in the left, moving to the left-hand side of the bell curve as things go forward. So to me, that sort of escalates the concern that providers should consider to some type of alternative payment model. I'm not necessarily saying taking risk, and we need to talk about that, and we'll do that in the ACO side of the house. But at this point, what is important to note is that Medicare is already making a new overhaul, and this year they called it the Pathways to Success. And in the Pathways to Success, they're actually amping up the requirements to move to risk. So I won't go through this next slide, but I put it in there for your reference. It's important to note that they're reducing the amount of time that an ACO can be in the ACO program without taking risk. It also says that it's in strengthening the incentive to moving to risk. So what they're saying is you can make more money, you have better chances on return if you take bigger risk. The result of that is the money's got to be removed from someplace else, and there's that disincentive for people, or not the disincentive, but the disadvantage for people not moving into the ACO. They are extending ways in which people to participate have the ability to do outreach to patients. The telehealth is specifically focused on pathway success, certainly not exclusive, but it's going to help people move faster in that regard. They're also figuring out new ways that ACOs can actually pay beneficiaries some incentive payments to participate. Haven't seen examples yet. I think they were written into the ACO applications because it's a bit broad, but I suspect it would be something like the ability to pay for care coordination or buying them scales for CHF patients. There are ways in which it will be a way to make it easier for beneficiaries to seek out providers who are into alternative payment models. I correlate that to patients who want to go to rural providers, but the rural providers are not participating in Medicare Advantage because it's really hard to translate that to the all-inclusive rate for a rural health clinic. And so what happens is the Medicare Advantage plan starts offering bells and whistles that you don't get under Medicare fee-for-service for the Medicare patients. So what happens is rural providers, because they can't financially sustain the contract with the Medicare Advantage plan, aren't in the Medicare Advantage plan, and patients leave them. This is this migration, out-migration, is also a great concern if they're not engaged in these opportunities. So that's another one that we need to address. And then there are new benchmarks that are going to be not just the provider's own benchmarks, but now it's moving to a regional perspective. So rurals will not be competing only against their own data. They'll compete in a region collectively. And that will be more specific as time passes. And so if rurals are not engaged and know how to do things like hierarchical condition category coding and the ability to demonstrate their story and the severity of their the disease state of their patients, then they will begin to not get benefit in the benchmark area. And then finally, I think what's really demonstrating the escalation is in that bottom paragraph, that ACOs that terminate their participation with Medicare. So used to, you could get in and say, I'm not going to stay in the ACO anymore because we're not able to do it or we're not doing well. Medicare's saying that you will actually have to pay in the losses, even if you weren't in downside risk. If you terminate your participation, you will be accountable for prorated shared losses. So they're stepping it up to making it more. It'll be more difficult to start in the game in the middle of this. You know, as things move along, it'll be really much harder than starting now and progressing into it, easing into it, than waiting until it's full-blown risk and you haven't even figured out what the severity of disease states of your patients are. So this year, Seema Verma spoke to all of us at the National Rural Health Association's conference in Georgia in May, and she pointed out some specific things that she considered rural offerings. One of them has been in existence for quite a while. It's the QPP, offering support for small and underserved and rural practices. It exists today, and you can find it on that qpp.gov website. It helps them extract some data, gives them some credits of being rural or small, might help them engage a little bit easier by getting support from them. They're also thinking that telehealth payment policies, which rurals have asked for a long time, will actually help them in engaging and providing more services like behavioral health that they have not been able to do before. There's going to be a big FCC grant that comes out this fall, again, expanding to broadband capabilities to support the telehealth, which is really positive. The biggest one, I think, that's really remarkable is the Medicare Wage Index. It was, what would I say, it was disproportionate for rurals on the same amount of work that was done for rurals based on some old rules, and they are making that adjustment this year that will help rural providers actually attract more talent with more ability to pay higher. So that's a positive. And then the fifth thing is that they're actually going to provide two primary care initiatives. One of them is the Primary Care First. Haven't seen the final rule drop on that, but it should be soon. And then direct contracting. There are 5 different options on that. I think the direct contracting is those who are more experienced in value-based payments, but Primary Care First would probably start to work for rural providers, so we need to really watch that one. What was absent in Seema Verma's conversation on this day was that she's not backing down on risk, on the acceleration to risk. She's not creating new exceptions for anyone. She's trying to create more options to accelerate people to move to the right-hand side of that bubble graph. Doesn't mean you have to go all the way, but they're not yielding, and this isn't going away. So I think that's really as important of what's not there as what is there. So my perspective on this is the bird's eye view is that for Medicare to maintain sustainability and for providers to sustain through the Medicare transformation, Medicare has the intention of bending the cost curve, and they have to purchase high-quality services. They want to know what they're getting in quality for the cost that they spend, and that is embedded in everything that they do. And this is an imperative for them in order to bend that cost curve. What's interesting, too, is that I think we're starting to see this year, yes, they're seeking to change the system both in delivery and payment. We've seen a lot of focus on payment, but I think that through telehealth and the behavioral health CCM that came around about 1.5 years ago, and the direct primary care, we're starting to see some changes perhaps in the delivery system. The result of these two imperatives is that engaging in risk is inherent in those, and it's not going to go away. My biggest concern, and I've said this already, is that there is a significant disadvantage for those who are not taking risk or at least engaging in some type of value-based payment. And for fee-for-service, there is no way to increase reimbursement unless you engage in risk. So those things, I think, are what is the basis of the conversation for what we'll have in the following webinars. So just to wrap it up, what I wanted to say, and this is a question that I want to carry throughout the next 5 webinars, is what is the rural option? And so I did this with my earlier series, but I wanted to tell you my experience in the field of why I see it's difficult for rural providers to not engage in this transformation. Number one, they are exempt. And they are so overwhelmed that if they are exempt, it does not seem important to engage. And the result of that, not engaging, based on what I've shared with you today, is that they are falling behind. It'll be harder to have all the incentives to help you gradually engage if you're not doing it now when those opportunities are here. You'll have to jump in the deep end the longer you wait. So I think it's really important to do activities even outside of participating in an APM, like voluntarily participating in NITS, understanding the reporting requirements, documentation of hierarchical condition categories, coding. The second thing is that a lot of the payment methodologies were based on high volume, and even to the point of rurals participating in an ACO. Small rural practice, even 100-bed hospitals, don't have enough volume generally to do their own ACO. It required collaboration, which is a whole other body of work. And so the cost to build infrastructure is pretty high, and the investment based on a couple of other strange things like the time lag of reconciliation of cost accounting, either up and down, create an unsteadiness on the return on investment, which makes that return low. The other thing is it's perceived in the old days, like capitation, that patients needed to be managed cradle to grave within a capitated arrangement because you wanted to control that. And I wrote that as the program is not designed for silos of the care continuum. In other words, it's hard to just be primary care but not be specialist, maybe not doing, for the commercial side, not doing maternity, on the senior side, maybe not having specialists that are in your community that you actually have at least contractual relationships with, if not friendly relationships with. So again, that's a different body of work to be able to look at cradle to grave cost and care and know how to manage that to the benefit of the providers participating in the ACO. So it's difficult to manage the total spend in the type of ACOs that you have now. I don't think it's impossible, and I think actually it's a really great opportunity because rural providers are really good at collaborating. Rural people in general are really good at collaborating. And the fourth reason is that the programs that rural providers historically have been under, particularly the all-inclusive rate in the rural health clinic setting, didn't require the documentation of the disease state. In fact, it just it wasn't that somebody was told not to do it. They just did what they needed to do in order to get paid. And the reality is, in pay for value, it's about payment based on the resources needed to care for that disease state. So they're willing to pay more for people who are sicker, but they need to know proof that that patient is sick. And so that's this hierarchical condition category coding that I'm talking about. And so historically, rural providers were not doing hierarchical condition category coding. Our story of the amount of work and care that's done is not documented in claims, and we are measured through claims. By and large, we are measured by the claims that payers, they measure everyone through claims. It's not just rural providers, but they look and do analysis on claims. That's the only data that they have. And if we are not documenting, then we are not showing our true story. And historically, that documentation did not align for the ability to be successful in value-based payments. I think that's something that's an easy change and something that we need to beat the drum on across the country. And the last one is taking downside risk. I came across this a couple of times, but actually more than a couple of times. Hospitals that are political subdivisions or those managed by taxing entities may have a more difficult time on explaining and accepting downside risk, especially in collaboration with other disparate tax ID numbers. I think I actually worked on this 20 years ago, and it was almost impossible because there wasn't really anybody that saw the ability to have a return. Now in this value-based world, I think there's a reasonable opportunity in collaborating to the point of doing this. We're going to talk about that in ACOs. We're also going to talk about that in clinically integrated networks. But it'll be interesting to see across the country the conversations of how to manage the taxing entities and dealing with the downside risk. So, the takeaway for this is that what is the option? What is the opportunity to receive an increase in payments if we don't engage? Or if we want to make a case, how do we make that case of what we do want to do? And if we are not reporting, regardless of any payer that we're dealing with today, everyone is looking at the value of the provider based on what they're billing. And so if we are not participating, we are perceived as low quality and we will be bypassed. I talked to someone in the payer community, and if they don't see the rural provider as a quality, Medicare Advantage plans can hire people to pick them up and drive them into the city. So we have to tell our story of the high quality that we do through claims data. And we have to talk about what value we provide to a payer. I look for this presentation and ones later on across the country of what value are we providing to payers who are buying our services. And we really don't talk about value in that way in rural health. We talk about the value of the rural health to rural communities, and we talk about the good work that we do to patients, but we don't talk about the buyers. And we need to speak their speak in order to be powerful and leverage with them. So that's what I see in this story that we're building today, and the first of the 6 series. So actually, I'm going to leave you with that. I'll take questions. We got about 8 minutes, and then I'll definitely be connecting with you on the website if you have questions, and if you want to contribute to any questions that I can answer at the next webinar, I'll be happy to do that.
Again, *2 will unmute your line for questions and discussion.
Hi, Shannon. This is Nate from the state of Maine. I was wondering if you could perhaps, as we move forward in this learning collaborative, help us find some examples of where a health system or an individual hospital may have utilized a community-based organization or partnered with another company or group to help manage a subset of the population of covered lives that they are managing, and perhaps had some type of demonstration of payment that resulted from caring well for or doing a good job in managing the needs of the health needs of that group. Are there any examples that we might be able to mine out of what's already going on in the environment across our country, so that we might start thinking about and sharing ideas with some of our hospitals?
Absolutely, yes. I think the hot button on that conversation will be about the participation in collaborative ACOs, and I'll be able to share some results of that. If that's, are you talking about, when you said collaboration, are you talking about with other providers to do some work that they're not able to do, or are you talking about just participating in a larger group and managing your own patients?
I think it's the former, where
okay.
It might be too high cost for the hospital and their existing staff to do certain types of disease management, whereas they might instead, or other services that help support disease management for a population, and they are essentially doing it at lower cost by partnering with this other group or organization. Is what I'm hopeful to find as examples of how hospitals can conduct good population health support or services at a lower cost with a good return, and be able to essentially help save costs and still have good health outcomes.
Yes, I'm gonna go back and consider this and let you know if it'll be in the next webinar, or which topic it'll fall into. But I'm thinking of several that come to mind that there's options to consider.
Okay.
Yes,
Great.
Thank you for that. Anyone else have questions?
All right. Hearing none, we'll give just another moment, but a reminder that the external SharePoint, the website is there. The webinar recordings will be posted there as soon as they're ready, as well as the slides from the presentation. So if you are not able to make a webinar presentation or a meeting live, the recording will be there shortly. There's also a forum for discussion, questions, answers, anything you need there, as well as a calendar of events that the webinar presentation schedule will be posted there shortly. I'm fighting a sneeze right now, excuse me. Our next webinar will be next week on Wednesday, August 7th at 2 p.m.
Well, thank you all for joining us today. If you think of anything, you have my email. I'm happy to answer or discuss things with you. And of course, the website that Caleb mentioned, there can be group discussion there as well. And yes, Kyle, you're all welcome to share the slides. With that, we're going to give you back 2 minutes